This is very important because we want to find the molecular structures and any metabolisms and any pathway in cancer cells, finally for finding the drugs, for finding targeted therapy for treating the malignancy and neoplasia. So this is very important because the mutated IDH protein have a different structure from the normal IDH. So it has been possible to develop some drugs that can inhibit the mutated IDH and not act on normal IDH enzyme. This is a targeted therapy, and this is very good for chemotherapy and for finding drugs for treating and curing the malignancies. These drugs are now approved for treatment of certain IDH mutated cancers such as acute myeloid leukemia. So, because of these drugs, this is important for knowing about the tumors that have mutation of IDH. Okay, for example, AML or acute myeloid leukemia have this mutation. So the drugs that are anti-IDH are very useful for these patients. Okay. We have some other cancers that show IDH mutations. Okay, for example, cholangiocarcinoma. What is the cholangiocarcinoma? When we say carcinoma, it means epithelial malignancy. And cholangio is for biliary tract. For example, for gallbladder and bile ducts. And the carcinoma that arise from the mucosa of bile duct, we call all of them cholangiocarcinoma. Glioma. Glioma is tumor of glial tissue from, for example, brain and central nervous system tissue. Glioma is one of the exception. You know, we have some exception for suffix oma. You know about them? As I said before, the suffix oma is for benign. But there are some malignant tumor with oma suffix. One of them is glioma. Okay. The other one, you know about them? The other one is melanoma. And the other lymphoma. Okay. Lymphoma is malignancy of which tissue? Lymphoid tissue. Any lymphoid tissue. Okay. The other one I said is melanoma. What? Is a type of skin cancers, and this is especially for melanocytic origin. The malignancy of melanocytes that are pigmented skin tumors like nevus, but very large and nodular and irregular. And the other one, as we said here, is glioma. This is malignant tumor of glial tissue. Okay. And the other malignancy, as we said in the previous slide, is acute myeloid leukemia or AML, that is a subtype of malignant blood cells with blood cells origin, malignancy from blood cells. And sarcoma, some types of sarcoma have IDH mutations. As we said before, sarcoma is malignancy of mesenchymal, yes, mesenchymal tissue. Okay, now we want to start the other features and the other hallmark of malignant cells, that is evasion of cell death. Okay. You know that the accumulation and proliferation of neoplastic cells may result from inactivation of growth promoting oncogenes in one hand, and in the other hand, inactivation of growth suppressing tumor or suppressor genes. Okay, as I said before, these growth promoting genes and growth suppressing genes, all of them are imbalanced in a normal cells. But because of some mutations, we have activation of growth promoting oncogenes, and in the other hand, inactivation of growth suppressing gene. Okay, because of this, we have accumulation and proliferation of the tumoral neoplastic cells. And also, we have mutation in the genes that regulate apoptosis. Apoptosis is programmed cell death. Okay. This is the definition of apoptosis. Apoptosis is a form of regulated cell death characterized by dismantling of cell into component pieces which are efficiently consumed by phagocytes without stimulating inflammation. Apoptosis is very different from necrosis in tissue examination by microscope. In the pathology, we can examine the tissue by microscope. Okay, we have sometimes necrosis in tumor. Necrosis is very dirty with very inflammation. Cell death by the inflammation, by the drugs, can cause necrosis. By apoptosis side is very clear because this is a programmed type of death, and the cells have program for this type, and after that we have no inflammation, and the cells die from its cells, and after that they can dismantle into some small component, and after that they phagocyte by the some cells like macrophages and monocytes that can phagocyte the piece of the remnant of the dead cells. Okay. You know that we have two ways for apoptosis: intrinsic pathway and extrinsic pathway. Okay, I think you know about the apoptosis. Both pathways finally result in the activation of a proteolytic cascade of some enzymes like caspase that finally can destroy the cells. The intrinsic pathway, also known as mitochondrial pathway, initiated by perturbations such as loss of growth factors and DNA damage, but extrinsic pathway initiated by other ligand and receptor that we call them fast ligand and receptor. So fast ligand and fast receptor can start the extrinsic pathway, but some DNA damage and loss of growth factor can start intrinsic pathway. Evasion of cell death by cancers mainly involve acquired abnormality that interfere with the intrinsic or mitochondrial pathway of apoptosis. There are many intrinsic stress that can initiate apoptosis. As we said, DNA damage can initiate apoptosis, also some metabolic disturbance or hypoxia, for example, because of insufficient blood supply for any area. All of them can start the intrinsic pathway of apoptosis. Now about intrinsic pathway. Activation of this pathway leads to permeabilization of the mitochondrial outer membrane and release of some molecules like cytochrome C. Cytochrome C initiates the apoptosis. And now we know that the integrity of mitochondrial outer membrane is determined by a balance between pro-apoptotic and anti-apoptotic members of BCL2 family. Which proteins are pro-apoptotic? Wax and bark, yes. And they are required for apoptosis. They can directly promote mitochondrial permeabilization. And on the other hand, the anti-apoptotic member of this family are BCL2 and BCLXL. Please remember this because maybe I have some question in the end of class or maybe a small exam, and please remember this, okay?
How many marks?
You should remember the points that I emphasize about them. These are very important for now, for your final exam. So the pro-apoptotic proteins are BAX and BAC, and anti-apoptotic factors are BCL2 and BCLXL. Also, we have another group of proteins, a third set of proteins that we call them BH3 domain only, or sometimes we call them BH3 proteins only, okay? They include BAD, beet, puma, okay? And these are pro-apoptotic, like BAC and BAX, and shift the balance between pro-apoptotic and anti-apoptotic family member by enhancing activity of BAC and BAX. So these three proteins can help the BAC and BAX for starting apoptosis and for making some pores in the outer membrane of mitochondria for cell death. So in this picture you can see that this balance is very important in normal cells, and in the cancer cells, in malignant cells, we have some mutations that can overexpress the anti-apoptotic factors. They can overexpress the activity of anti-apoptotic because the tumoral cells don't like the apoptosis. They want to live in any situation, okay? And also maybe we have some mutations for decreasing the activity of pro-apoptotic factors. So finally, when the sum total of BH3 domain only overwhelm the protective activity of BCL2 and BCLXL factors, BAX and BAC are activated and form some pores in the outer membrane of mitochondria. This allows mitochondrial cytochrome C to leak out into the cytosol, where it binds to APAF1. This is one of the anti-apoptotic factors, and activate caspase 9, which in turn cleave and activate some other caspase like caspase 3, and finally they can cleave DNA and other substrate to cause cell death. Okay. Who can explain this picture? 3 minutes. I said all of them in the previous slides, but some of you are on your phone. Now I want to choose a student, okay?
بيأثر على P53 response اللي بتأثر على activation ال pH3. تمام؟ يعني احنا فكرة 3 mechanisms لحتى تأثر على السن
بتشرح الأحمر والأخضر مع بعضهم؟
لا انت اشرح الأحمر كيف يأثر على الأخضر بس.
مش هشرح ثاني شرحنا هيك شو بصير
عشان تنقيك لحتى شو بصير.
لا ما قلتش لك سألتني هيك
هو الاشي اللي بيقدم السنسور مارك مش سلبات. احنا فهمنا السلبات هو النورمال كيس.
يعني بس نعمل اسم اللايف شو
بالنورمال السلب.
بيمنعوا عكس بعض
بيمنعوا العكس بقى.
شو هي ال ARP؟
Okay. Who want to come here? Apoptosis have two major mechanisms. One of them is loss of p53, and the other one is increased expression of anti-apoptotic members of BCL2 family. About p53, you know that p53 mutation is very important mutation, and we find them in many tumors. And now we have some way for finding this mutation by molecular study, PCR study, and also sometimes by immunohistochemistry. Immunohistochemistry is a diagnostic way in pathology that we can use some stains, some staining way by the process between antibody and antigen. We can use this and we can find some specific molecules and some specific antigens on the cells. For example, p53 is one of the factors that we can find this by IHC or immunohistochemistry in pathology. And in the tumors that have a higher grade and have bad behavior, this mutation is very high, and we can find them by the staining way, by the immunohistochemistry. As we said on the picture, TP53 directly acts on PUMA, that is a pro-apoptotic member and can cause apoptosis. So mutation of P53 can inhibit the apoptosis. Okay, the most common abnormality involve loss of p53 function, either by way of TP53 mutation or overexpression of p53 inhibitors, that we call them edu.m. This is for p53, but we said that some tumor use other way for evasion of cell death. Some tumor use overexpressing of anti-apoptotic factors. Other cancers evade cell death by overexpressing BCL2, which can protect cell from the action of BAC and BACs, that they are pro-apoptotic members of the BCL2 family. The translocation, translocation between chromosome 18 and chromosome 14 that happen in a specific type of lymphoma. For example, in follicular lymphoma, we have this type of translocation, and we have overexpression of these anti-apoptotic factors. Overexpression of BCL2 is a common event leading to the protection of tumor cell from apoptosis. So, in this type of tumor, we have tumoral involvement because they can escape from apoptosis. This tumor formation and proliferation is not because of very proliferative activity, okay? It is because of loss of apoptosis and loss of cell death. So this type of tumors, like follicular lymphoma, are very indolent, you know, are very slow growing. For example, for some years, for many years, maybe patient have some lymphadenopathy. Lymphadenopathy is enlargement of lymph node in any part of the body, okay? Some patients have lymphadenopathy for many years, okay? And they can behave very good and indolent. One of the best understood example is found follicular lymphoma. As I said, follicular lymphoma is malignancy of lymphoid tissue, okay? So this type of lymphoma is for B-cell lymphocyte, is for B-type lymphocytes, and have this characteristic translocation between these two chromosomes. This is very important, translocation between chromosome 14 and 18. Sometime now in patient with lymphadenopathy, when we think that this is follicular lymphoma or other type of lymphoma, we can use and we can find this translocation by molecular study for exact and definite diagnosis. Okay, sometimes diagnosis is very difficult by only microscopic examination or immunohistochemistry, and in this situation we can use the molecular study for finding the exact gene, the exact deletion, exact translocation, like this example. This translocation result overabundance of BCL2. Okay, this translocation finally can cause overabundance of BCL2, and BCL2 can protect lymphocytes from apoptosis and allow them to survive for abnormally long periods, producing a steady accumulation of B lymphocytes that result in lymphadenopathy. Also, we have other example. For example, chronic lymphocytic leukemia. It appears that BCL2 is upregulated because of loss of expression of some specific microRNA that normally can dampen and can decrease the BCL2 expression. So, in follicular lymphoma, the overexpression of BCL2 is the cause of disease, and in CLL or chronic lymphocytic leukemia, this is because of expression of some specific microRNA. And also many other